How's that? I have more, but this is the most exciting thing, like just these connections. You folks. So as you know, I'm Mindy, I'm chair, and as we already talked about, I took over from Julie Dorsey, who's moved up into the associate dean role at the School of Health Sciences and Human Performance, and she continues to support us endlessly. Oh, good. Here's Dr. Germain joining us. Um, so the current president, hi, Dr.
Hi,
Germain.
how are you? Hey, Amanda.
Hi, how are you?
Good to see you.
Good to see you too.
Oh, Sophia, hi.
See,
I see you on here too. It's so fun. I already had my
right.
hair in a bun, so I was just trying to make myself look a little more presentable.
Oh, all right. So I just want you to know I'm getting texts that people, it's a really bad windstorm around
Oh, it
here.
is
Like
bad.
like Dr. Scott does not have any power. Somebody else
Oh,
has a gas leak,
Oh,
right? So there's no right. So just so you know,
okay, no
yes.
things are
problem.
going down around Ithaca as we
Mm.
speak right now. So
Oh,
Yeah, power was on and off today.
mine too.
Mhm.
Mine too. Okay, so I was in the middle of my fancy introduction.
Okay, sorry. Hi.
Okay, back to that. Okay, so the current president of Ithaca College, Lejeune Terry Cornish, often reports that students are our why, and we like to think of our alumni as our results. So
mhm.
this series combines our why with our results, right?
I like that.
And yeah, thank you, thank you.
Hmm.
Um, and we're looking at our current and future success with the folks who already have the success, and we are so grateful for your sharing of your knowledge and your abilities and of course your time. So the speaker series was born a few years ago. We had two former students, Emma Robinson and Julia Gamebarg, decided that, as you folks know, when they were students, I'm sorry, my dog just threw a bone down the stairs. Since COVID, every time I go on Zoom, he is such a little jerk. Like he's eating toilet paper back there. He just threw a bone down the stairs. It's like, oh, all right, I'm back on it. I'm sorry. It's been a day. All right, so Emma and Julia had this idea and they went to faculty member Jenna Heffron, and together they started this whole series. And that was in the middle of COVID, and it really was a lifeline. It was really heavily attended because what else were folks going to do on a Wednesday night during the middle of COVID? And it was actually really fantastic. So I think that's all I have to say. We this is the first one for the semester, and we thank you. I'm gonna turn it over to the two students who have taken on the torch from Emma and Julia. We have Lauren Rodriguez and Axa Roy, our new moderators, and they're the ones that are organizing this series for us now. So I thank them for their efforts, and I'm going to turn it over to them.
So before we start, just to let everyone know about the Zoom closed captioning and live transcript. So for the live transcript, click on the CC live transcript at the bottom of the Zoom window next to reactions. And option 1 is to show subtitle, which will make captioning appear at the bottom of the screen. And to turn it off, just click on it, the CC live transcript again, and then hide subtitle. And then option 2 is to view full transcript, which will make a live transcript appear on the side of the Zoom window. And if you want to simultaneously view the full transcript in the chat feature, just go to the top of the live transcript window and click on the downward facing caret and then pop out. And then you can then move the live transcript anywhere on your screen. And then for the chat feature, it's at the bottom of the Zoom window next to the participants button. And similar to the live transcript, if you click on the chat button and the caret at the top of the chat window, you can choose to pop out the chat and move it around your screen. So we welcome you to use the chat feature throughout the presentation during the question and answer period. We'll be fielding questions from the audience through video, audio, and the chat. So just engage with the technology in whatever ways feels best to you. And just to let everyone know, the session will be recorded and edited with the full transcript and will be posted to the iCut YouTube channel for everyone to access.
So tonight is our first speaker series of this semester and our 4th annual speaker series. And today we have the pleasure of hearing from our alumni, Amanda Stephan. Amanda is a senior level occupational therapist at the Center for Brain Injuries Extended Recovery Unit at Hackensack Meridian JFK Johnson Rehabilitation Institute in Edison, New Jersey. She's received her Master's of Science in Occupational Therapy from Ithaca College, as well as her Bachelor of Science in Occupational Science. She is a young professional serving 5 years with an emphasis on serving the adult population with the neurological deficits. She's highly active within the occupational therapy department, serving as one of the leaders of self-care groups and cooking groups at ERU, as well as chief editor of the OT Interdisciplinary Newsletter. She just earned her certified brain injury specialty certification. She has been a clinical instructor for a level 2 occupational therapy student as well as observation students. She has joined the outpatient wheelchair clinic to better serve her community members in identifying a wheelchair to suit their mobilities related and activities of daily living. So without further ado, I will turn it over to Amanda to get us started.
Great. Thank you guys so much for that great introduction. I am going to share my screen so I can share my presentation. Oh, it says host disabled participant screen sharing. Are you able to make me co-host or something?
I think it should be able to work now.
Okay, I'll try. All right, here we go. Great. Let's see here. Okay. All right. So I don't know, I'm not too Zoom savvy, but if like there is a chat, like a question in the chat, can the moderators like let me know and I can just pause? Okay, cool. All right. So thank you guys so much for that great introduction. As you guys said, my name is Amanda. I've been an OT for 5 years. I work with Hackensack Meridian Health at JFK Medical Center. To speak a little further about my credentials here, I am certified stroke rehabilitation specialist, which is a course that I took. I forget when it was like 3-day course or 2-day course. It was over virtually, but I believe they're in person now. It's very popular and there's like a wait list to get in. So I was lucky to get it completed. I believe I did it in the summer of 2020. But it's a great course, very professional, like OT, PTs, and it was such a great learning experience. And I almost want a refresher, to be honest, because it's just so factual and very informational. And that's what kind of sparked my interest in the neuro-based population. And then I further went into recently getting my certified brain injury specialty certification, where you do a self-study, you study on your own, you get the textbook, and you take, I think it was like 80 or 100 question, like multiple choice test. I've also gotten a lot of different experiences by working in the brain injury department. I've gotten professionally trained for like behavior management techniques and like hold downs and things like that, as well as splinting a little bit, and various other things that I'll speak about throughout the presentation. But to give you an idea, because I will refer to a lot of it right now, I'm in an inpatient rehab setting within the brain injury unit. So our brain injury unit serves as an inpatient rehab, and the patients are there 2 to 4 weeks. And then we actually have an incredible additional service, which is called the Extended Recovery Unit, which people can go to if it's not time for them to go home, or they might end up going to a skilled nursing facility. But it is a rehab, and the patients might be there for 4 to 6 months. And right now, I integrate more of that, truly where they're going to function and working on their independence to either home or to a community reentry program, and incorporating like community activities. We go all different places, and I'll touch on that throughout the presentation. But let's get started. So today's objectives are to achieve an understanding of the basic medical-based stroke concepts, identifying the benefits of occupational therapy for stroke rehabilitation, understanding the differences in various therapy settings, and describing the day-to-day routine as well as roles and responsibilities of a stroke-based OT. So some general stroke information. So what is a stroke? It is the blockage of blood in an artery. There are two types of strokes, so ischemic and hemorrhagic. Ischemic is blood clots in an artery, and it is medically removed. Something that is used quite often if the patient qualifies is TPA, which is a medication given. It is only given within a 3-hour time frame, but now like the FDA is coming up with all different types of TPA, so that time frame might be different for like from month to month as like new medications are coming out. But that's a really big factor in recovery, because it's incredible that I've seen such a difference in patients that have and haven't qualified for TPA, because if they do qualify, they have a lot more motor return and function in their arm and their leg. But unfortunately, for those that don't get TPA, it takes a little bit longer to regain the function. The second type is hemorrhagic. So this is where the blood vessel ruptures, causing a bleed in the brain. This might also be a part of like impact due to a brain injury. So the patient might need medical intervention, an external ventricular vein, which drains like the intercerebral spinal fluid, a craniectomy, or medication. So here on the right, I have a picture. This is an example of a lot of folks that I see who have had a stroke or a brain injury, is they have to get a craniectomy. So you see the picture of the guy on the left. The craniectomy means a portion of their skull is taken out. And this allows for the edema in the brain to kind of calm down and decrease the swelling, because it's providing too much pressure and there's nowhere for the fluid to go. So they take out the skull, that's like an OR procedure, and then they would come to acute rehab with a helmet. And you would have the patient wear the helmet when they get out of bed, they're walking, doing anything like that. Even I've given people a shower with the helmet on, and we just don't wash the hair because you're most likely not able to wash their hair. But that's just an example of a procedure that they might have. While they're with us, they might like have the opportunity to get the cranioplasty, which is where that skull, whether it's their skull or an artificial skull, is placed back into their head. And this picture here on the right, it's a very symmetrical head, but some of the folks, it's not so much, but you know, they have that protection, and that skull is so important as a barrier to your brain, because and that's the importance of the helmet, right? Because you need the helmet out of bed, because it's literally your brain and the skin. But then when you do have your skull, like all of us do, is you have that skull as a barrier to protect your brain. All right. So here's just some common information in regards to the left side of the brain function and the right side. You know, when a stroke happens on that right side of the brain, you know, this will affect vision or organizing information, memory issues, decreased awareness of deficits, things like that. With right-sided infarcts, you're most likely to see like a left neglect and a lot of visual deficits. And this helps you create a picture of like, gives you an idea, if you're able to remember each side of the brain and what their deficits are, for when you are maybe reading like an occupational profile and it says, okay, patient presents with right parietal lobe infarct, then you're like, okay, so the left side of the body's impaired. They might have vision issues. They might have difficulty, you know, with spatial relationships, music or art awareness, like it says here, things like that. So it's really important to understand like each area of the brain, as well as each lobe and things like that. So neuro class helped me in this way for sure. All right, so in this recovery phase, so you're medically managed by the doctor, and of course they're recommending therapy. So one key word that I wanted to touch on was neuroplasticity. So the idea of neuroplasticity is creating new connections in the brain based on the area of deficit. So they say in the research, within the first 6 months of recovery, you see the greatest return in motor function, but it doesn't stop there. So you can use that 6 months. Selling a patient that the first 6 months of recovery helps them is kind of used as a motivator, but also you don't want to scare them because there's continued growth in gaining motor recovery in your arm or your leg or your language or anything of that nature. So where does OT fall into play with neuroplasticity? So we help focus on, mass practice, visualization, hand over hand, tactile cues, providing a visual cue with a mirror in front, to send that feedback, because our goal is to recreate these new connections. And even if you provided hand over hand to grab a glass, doing that repetitively would help kind of make those connections meet so that eventually and hopefully they're able to maybe use their arm to drink again. All right, so here we are leading into specifically OT in relation to stroke. So as we know, occupational therapy focuses on everyday life activities, promote health, wellness, ability to participate. So specifically, OT might work on bathing, dressing, toileting, IADL activities, driving in the outpatient setting, upper extremity function, all those things. And based on these neuropopulations, in different stages of their therapy services, of course, you're going to go through an evaluation, intervention during their time there, developing goals of what their deficits are, and creating a plan in collaboration with the interdisciplinary team. The beauty of OT is our skill set in knowing a lot of medical information and analyzing what's going on and figuring out the interaction between the person and specific OT domains. So that is where we come into play and we help in the recovery process. So just to paint a picture, I have a little case study here, and then we're going to talk about the OT domains. So Bob here is a 74-year-old male with a right ischemic stroke in the parietal lobe. He received TPA and now presents in the acute rehabilitation. He presents, the C means with, I was writing this before. He presents with difficulty attending to items on his left side and decreased functional use of his left upper extremity and left lower extremity, yet is gaining return proximally at his left lower extremity. He's a father, husband, grandfather. He is very routine kind of guy, showers daily, takes a dog for a walk. He enjoys golfing, cooking. He retired 10 years ago from working in accounting, and he wants to get back to his daily activities for being a grandfather. So taking this case scenario, I just wanted to dive a little deep into the OT domains just to get a sense of how important we play a role in all the domains that are featured in the OT practice framework. So as it's stated, he is a very routine guy. He showers daily. So tapping into the performance patterns and what those routines were, sticking to that will help make him feel better about himself, and maybe he'll make him perform better, and kind of sticking to what he's used to will help in his recovery process. If I had a patient like Bob, I would maybe make it a routine to give him a shower, maybe Monday, Wednesday, Friday, and then work on his upper extremity or whatever have you on that Tuesday, Thursday, just to kind of keep that routine and the habit, because that's what he's used to doing. Of course, being a grandfather, maybe he picks up the kids from school. That's his role, and that goes hand in hand with the performance factors, and what he's going to be doing, and even environmental factors to consider. Maybe he's a family guy, and you have to think about the stimuli in the environment if you were to go to a holiday gathering, and if it's too much, then he would recognize it and have to maybe alter that. Incorporating his values, beliefs, spirituality, of course, And like it said, decreased functional use of the left upper extremity, which ties into the performance skills, motor skills, processing skills, things like that, to be able to incorporate use of his body to complete activities. So common stroke-related impairments are ADLs, hemiplegia, which is impairment to one side of the body, balance, sensory, language, whether it's expressive language or receptive aphasia. You learn so much in so many ways in collaboration with the speech therapist of how to communicate with patients, which I find fascinating, and I learned so much from my speech therapist as well, whether it's like a communicative device or like a simple paper that says yes and no, and you just present a simple question in a yes/no format, and they're able to point to it, or even doing it with colors during a session. Visual deficits, depression, or any mental health things, cognition, posture, ataxia, which is it's like over excessive movement of a limb. Okay, so they don't have control of their limb. Right now, I have a patient and he has ataxia of both of his limbs, but more in that right limb. And they say, just to give you an example, is like to weigh down the limb. So I have him use a weighted utensil for feeding. This is something I've been focusing on with him. And I've put like a 5-pound like wrist weight at his shoulder proximally. And I think I added another one at his wrist too. And it was like 2 pounds. So it was like 7 pounds excess on his arm. And in the CSRS course, they said over 5 pounds will help. So that's why it's like a lot. But of course, they're also weak. So you have to think about that. But it has improved. But I won't forget it, Amy, is in your course for the kids is like proximal stability equals distal mobility. It's not in my brain forever, but it's so true because I've been having him sit in the edge of the bed, but if he's in the wheelchair, he's got that proximal control. And then even if I'm able to prop his arm on the tray table and I still have that weight, it helps him. It's like, it's crazy. So you incorporate all these things and it's honestly such a trial and error. Like first I started with 5 pounds and I'm like, let's bump it up. So then I bumped it up to add 2 more pounds. So it does really help. And you learn and you remember all these little things. Then there is apraxia, which is the control of your movement as well. It's different than ataxia. Ataxia is more of like, you're trying to reach for the cup, example, and you're like this. But like apraxia is, I say, take the cup. And they won't take the cup because they don't know how to motor plan from their brain to the arm to reach for the cup to take it and drink. So that kind of can go hand in hand with the language and functional cog, and you can work with speech with that. So those are just a couple examples for you. So how does an OT address these deficits? So we provide a client-centered approach. What are the patient goals? Thinking about what they want to do and creating autonomy and salience in your sessions is super duper important. So even if they like music and you can play music during your session, have at it. I'm stretching their arm. I might as well play music, creating a holistic approach and considering the domains and considering all different variables. Creating task-oriented intervention sessions for motor-related skills. So a patient enjoys cooking, but has limited fine motor abilities. So you're going to teach them the use of a rocker knife or a cutting board with spokes so that they can enjoy a meal and can get back to a task that they previously enjoyed. And thinking about compensatory or adaptive strategies like hemi dressing techniques or, visual techniques as well. So here we have some evidence of our role post-CVA. We have proven to decrease rates of post-stroke readmission, which is incredible. OT is the only spending category that reduces hospital readmissions, and investing in OT has the potential to improve care quality without significantly increasing overall hospital spending. So, I think this is great for our profession, I think this is incredible, and for our job security. And this proves that we are essential. Like, we are needed in this role to help these patients and individuals. We've proven to decrease caregiver burden by incorporating into education sessions and incorporating caregivers throughout. Just to say a little bit about that, we provide a lot of family training, and family might be there frequently. So you are constantly communicating with them and providing all of your expertise and education, so that the goal ultimately is for them to take them home. But sometimes it's not the case. But it helps with them going through this time as their caregiver or their family member, just recently had a stroke or a brain injury. Improving quality of life with client-centered practice through reinforcement of client-centered approach, helping, implement and how important it is how we serve the stroke population. So here we have evidence supporting OT's role post-CVA. So evidence-based practice for stroke rehab to improve the upper extremity function includes mental imagery, constraint-induced therapy, and mirror therapy. I'll talk about those three on the next slide. So why incorporate evidence-based practice? To decrease the effects of disability on and increasing the quality of life of stroke survivors. In conjunction with the standard OT practice, this study stated that the usage of dynamic orthoses like these helped improve performance skills. Of course, the study was limited because not all therapists use those devices, but it was shown to help improve function. OT goal with evidence-based practice is to identify effective strategies to maximize that patient performance. I just have to grab a tissue really quick. I'm just getting over COVID. Okay. So speaking about mental imagery or mental practice. So this involves an individual visualizing performing a task or any bodily movement without having to physically perform it, and thus it resulting in stimulation of the neural system. So this website here, Sabo Mind, provides different audio things that you can listen to. And it's like, it talks you through, I'm using the example of the cup again, but it talks you through how to pick up a cup. And it's like a 3-minute segment. You can just Google it on your phone before you go to bed. And it just like talks you through. It's very therapeutic. And this is focusing on, sending those motor messages from your auditory system to your brain. And that's still incorporating that neuroplasticity. Here we have constraint-induced movement therapy. So you're going, this here, the gentleman has the mitt on his unaffected limb, and he's going to perform a task with the affected limb. It could be something as simple as picking up a toothbrush, or it could be a little bit more advanced like this picture shows. It's designed to improve the upper extremity function and restricting that healthy limb to force the affected limb to function. And they might, because what you'll see is they'll have a tendency to use their non-affected hand for a lot of stuff, but you want to force them so they can get improvement in that affected side. Here we have mirror therapy. So you place the affected limb inside that mirror box, and the unaffected limb is in front of the mirror. So this lady here, she's looking into the mirror and it's providing visual feedback. So you might have a patient just like open and close the hand, just like 10 times, and they're visualizing it. So same thing, increasing neuroplasticity, you're mass practicing. There's a lot of different like protocols for mirror therapy. So it's a very interesting area to dive into. Okay. So to touch a little bit on each area of each setting. We have acute care, inpatient, outpatient, and cognitive rehab that I'm going to be speaking about and giving some examples from my hospital. So here in acute rehab, as a therapist, you might see like 7 to like 10 patients a day, if kind of sometimes. And I've covered there a lot, even on the holidays or when it's needed. But you might see a patient anywhere between like 12 minutes to 30 minutes. So it's really quick. You're in and you're out. You establish like here, you establish if there are deficits and if therapy services are needed. You determine if the patient is appropriate for caseload and or they're going to be discharged. And in that evaluation process, you're identifying those deficits, and you might focus on what is listed here, you know, ADLs, transfers, mobility, education on those caregivers. So you might not see someone for more than like 4 sessions, or maybe up to 6, or maybe just 1 session or 2. Of course, you're consulting with a therapy team. And at that discharge phase, you're going to ask yourself, all right, are they're going home, or would they benefit from acute rehab? And if they're going to go home, do they need any DME, which is durable medical equipment? And then you either have to work with the social worker to get the equipment covered by insurance, or patients purchase it out of pocket. Or they would go to an inpatient rehab setting, which is where I am at, or a skilled nursing facility. So here for the inpatient rehab, we're focusing on a safe discharge home. So working primarily on self-care, ADLs, you know, teaching them adaptive techniques, adapting the environment, incorporating any types of devices like a shower chair to a grab bar to a long-handled reacher. You know, you're teaching them that during therapeutic like activities, like whether it's picking up, you know, cones off the floor, or maybe even to use it to pull up their pants. Working on instrumental activities of daily living like meal prep, money management, parenting skills. You know, you might do a cooking task, like a real full board cooking task, make an omelet, have them chop the pepper, have the cheese, crack the egg, turn on the burner, safety management, making sure they turn off the stove after doing that task. So it all ties in, and I really have learned, I feel, is to do real life scenario situations. Like having them make an omelet will tell you how much, you know, how much they're lacking in safety awareness, or, ooh, they're not very safe using a knife. Like I got to teach them a different technique. Or maybe, maybe they shouldn't use the stove, but they could do some prep work seated at the tabletop and let the caregiver go to the stove and do that. Addressing underlying deficits, overall weakness, upper extremity function, vision, introducing coping strategies to support the psychosocial changes. You know, at this point, maybe someone's at like a month and a half post stroke, and it's kind of setting in, and they're realizing that, you know, shoot, my arm and leg don't work. And how am I going to overcome this? You know, I'm a father. I got to take my son to soccer practice, whatever have you. Like, it's going to alter their role and routine, and you have to talk them through it. I just had my patient today say, how am I going to be a mom again? And she's in her 30s. So it's just something to really take into consideration, and how you can support your patient. You know, sometimes sessions, I'm just talking to the patient and providing so much support. You know, say I wanted to go in, all right, we're going to get them up, we're going to, you know, practice like a toilet transfer, or, you know, whatever have you. And they just might have a down day, and you're just going to take it, and you will make it worthwhile for them and support them and provide whatever they need. Training family members and caregivers. Like I had said, you're going to practice that closer to discharge, you know, recommending any home modifications. Something that I realized is, you know, you get to know different companies that can come out to the house. You can provide phone numbers. You can say, hey, you should call this company. They do a free evaluation. They can come in. They can recommend, you know, stair lift, ramp, grab bars, change in the whole shower bathroom situation. And you can either go with them, with the company, or you can call Joe Schmo from your town and they can do it, but you could take their recommendation, or of course the OT recommendation. But it's nice for them to go out to the house and be like, oh, hey, this would work better or this wouldn't. Just to give a little example of what we have at JFK, the Sabo mobile arm support, that's a gravity eliminated piece of equipment. It's really cool. I honestly don't have a lot of experience with it, but I'm working on it. So, and even just like in that gravity eliminated plane, you're gonna find a lot more function. Something that I learned from work is the use of a powder board, which is like this big wooden board. It's probably like 4x4. And you have the patient lay on their side. They place their good arm underneath the board and their affected arm on top. And you might use like an arm skate. So they're in that gravity eliminated position. And you're able to really see any proximal control that they have at their shoulder, where you can facilitate the use of the scap. And then you might have to block at their elbow to work on shoulder flexion and such. But I found that really beneficial. And even if you keep up with it and work on it with the patient every week, you'll see the progress, which is really cool. The BioNS is this picture here. It's electrical stimulation. We had a brain Q research, which was a device that went on your head and it was like electrical stimulation. So they were exercising for like 1 hour, 5 days a week outside of therapy time. So that research is still in the works. So here I have some examples of, this is where I am. So the extended recovery unit. So I host cooking group. This is for 3 to 4 patients. It's super fun. We meet and we plan the activity. So they fill out like, how do I feel I would be cooking pre-injury? And then it's like a scale 1 to 5, 5 being the best, 1 being not great. And then it says, how do I feel I'll be cooking currently? So it's kind of, you see that compare and contrast, which is interesting, because then it also, you see their insight to be like, okay, do they really think they're going to be good at cooking right now or not so much? And then one of the cooking members comes and goes to ShopRite. So we go to the grocery store, we do a car transfer, or we get in the wheelchair accessible van, take them to ShopRite. We work on navigating the parking lot, looking both ways, navigating the grocery store, you know, considering, like I said, the, I forget which domain for the OT domains, but the stimuli in the environment, like if we go to the grocery store in the morning, it's going to be less crowded. But if you go at like 3 o'clock, it's going to be busy, or even lunchtime. So considering that and visual scanning, following a list, the whole gamut. And like I said, you know, putting them in that environment. And I know some places you're not able to do that, but it's so important. And you really see the deficits come out, if there are any, but you also see their strengths. This here is called self-care group. This is something that I started that was something that stemmed from my supervisor. She went to a TBI model system conference, which is where, so different hospitals qualify to be a TBI model system organization. And our organization was, and I think is still, but I'm not positive. And she learned about how a OT incorporated a self-care group where she did like facials and pedicures and grooming for men and women and things like that. So I've taken the lead and I have a group of 8 to 10 patients. And it also is a great opportunity to have an interdisciplinary approach, because sometimes like a speech therapist will come and have it as her session, and she'll see how the patient does with command following and following steps and procedures. So the idea of the group is to look good, feel good. I take them through like a 6-part process of a facial routine. So like cleansing, exfoliating, and, you know, taking them through the senses and to really engage them in what they're feeling and the grittiness of the exfoliant and things like that, or even the feeling of the toner and how the toner is cooler on your face versus like the other stuff. They get a little hand massage. So this has been my baby right now. And I'm potentially going to do maybe research on it to see effects of the patients. but it's in the works. I've only done it like maybe 5 times or so. But yeah, it's really cool. And lastly, this is a Love Your Brain yoga program. This is a nationwide program, actually. It would be something cool to look up. It's a 6-week program, and there's actually community reentry, community outpatient programs too, that people can come from the outside versus like internally. But 6-week program of yoga and an interactive session at the end, and it takes you through a session, and it's really great working on resilience, and all the patients are there, you know, for the same reason, and it kind of just like brings everyone together, which is great. Okay. So outpatient, this focuses on maximizing safety and independence. You know, you're focusing on educating and promoting healthy lifestyles to minimize the risk. Here in outpatient, the patient might be coming in recognizing like, oh, hey, I'm not able to do that. And I didn't realize when I went home, I wasn't able to, you know, go down like a certain type of stair or complete something in the kitchen. Something outpatient could do is working on community mobility, driver training, alternative forms of transportation, regaining function of the hemiplegic upper extremity. A hemiplegic is like a similar word to hemiplegia, just like a altered way of saying it. And spasticity management, which is something that I've learned a lot about, and like tone management. So the hyperactivity of a certain muscle, or that you would have to work on, whether it's like with casting or collaborating with the doctor in terms of getting Botox or injections and things like that. Issuing home exercise program, developing ways to compensate, remediate different things, and identifying strategies to overcome barriers to sexual activity and intimacy. This has been something also a big topic that one of my colleagues is focusing on for her doctorate, is like addressing sexuality, activity, and intimacy, and how it's not necessarily approached in the OT world with patients as much as it is needed. So this is something I think in the next few years that we will incorporate and be able to become a little bit more knowledgeable on, and maybe even more comfortable to address with our patients. So here at JFK, we have like a driver rehab program, the BITS, which is a Bioness integrated therapy system with like touchscreen interactive, SaboFlex, serial casting. Serial casting is like related to the spasticity, like I said. So it's a hard cast, like if you were to break your wrist, and it's like a hard cast where everyone signs your name on it. It's very similar concept, but you might like say they have a lot of tone this way, you might try to extend them as much as you can. You would cast it, leave it on for 48 hours, and then cut it off, see how much range they achieved, and then you might extend them a little bit more, cast again, and it really does sometimes break up the tone, which is awesome. Lymphedema, animal assisted intervention. At my facility, we have a facility dog. Her name is Biscuit. She is awesome. She's a golden lab, and she's a part of Canine Companions, and she does different commands, integrating her into therapy sessions. It's been a really great learning experience, as my colleague is new to that as well. But you know, today, like giving a patient a command to locate on the dog's body, like where is the head? And he pointed to the head, working on vision and command following. It's been a really great experience. We have an outpatient cog, which uses the Armeo, which is similar to the Sabo gravity eliminated device, but it's a little different. And then we have integrative therapies like Reiki and Jinjitsu and mindfulness and yoga, things like that. So just to touch on the day in the life of my everyday, I know I've touched on it here and there throughout the presentation, but you know, I go to work, create my schedule for the day. I have 5 to 7 patients, 30 to 60 minute sessions. As I said before, I have certain patients performing ADLs, whether it's 2 times a week, every day, or maybe 3 times. checking group schedules, facility schedules. If there's any new evaluations, reviewing the occupational profile, the history, physical assessment. I might be able to collaborate with a therapist that previously saw them to get maybe their wheelchair dimensions, things like that. Treatment planning, revising goals, collaborating, things of that nature. Determining like the best time and day to complete tasks. Say someone's not a morning person, I'm not gonna go see them in the morning. Or if they need to eat breakfast, I'm gonna go after breakfast and make the most use of my time. I gave the example here, like if I kinesiotape someone, I'm not gonna do it pre-shower or the day before because I know it's gonna get wet, even though it technically can get wet, but I feel like the best results are if it doesn't get wet. And completing outcome measures like, the modified Ashworth scale or the 9-hole peg test, like what we learned in school, box and block, things like that. And then you can monitor it week to week or things like that. So if there is a discharge, I have to think about, okay, has family been in to be trained? What durable medical equipment might they use? Does the patient need a customized wheelchair? I'll touch on that in a second. Something that is done on a daily basis, half-hour basis, is you're collaborating with your team, working on their out of bed tolerance, out of bed, back in bed, patient participation, co-treating, which is something that my facility is able to do. Some folks are not able to do that, but for example, like I wanted to work on vision and functional cognition, and the rec therapist incorporated a game like Guess Who. So the patient had to visually scan and describe a certain thing for them to look for. And I work with all the disciplines, and it's a very, very unique experience. And I'm able to target my goals as well as the opposing therapist can too. Completing meetings, we have care plan meetings completed every 2 weeks into a patient's stay and quarterly to discuss the progress. And then team rounds where you're going to meet with the doctor once a week and the team to discuss progress. Something else that I do that's unique is I'm a part of the outpatient physical medicine and rehab wheelchair clinic. So this is where patients from the community come in. They have a script from their doctor and they are deemed appropriate for a customized wheelchair. So here I work in collaboration with the doctor, myself, and the assistive tech personnel. And we evaluate the patient, their manual muscle tests, range of motion, postural alignment, their home setup, things like that. We're determining the best seating positioning device for them. I then have to write a letter of medical necessity, which is a formal letter. It's very long and it's very repetitive, but I'm justifying to the company why they need this certain wheelchair frame or why they need the tilt and space feature for pressure relief due to their wound. So it's based on certain deficits. The ATP goes to the home, does measurements. Okay, the home is equipped for 18 with wheelchair, so it'll fit through the doorways. And then this overall is like a 5 to 6 month process. So it does take a good amount of time. So lastly, to conclude my presentation, OTs have such a various role in each setting and it's not all the same. I have colleagues or classmates that I'm still friends with that we talk about all of our settings or compare and contrast, and that everyone does something different. So, and every day, you're focusing on all the OT domains for individuals with stroke and how you can incorporate it, things like that. Assessing their physical, their cog, their emotional, what their performance is, what they want to do. Emphasizing and encouraging patients to attend therapies, support groups, engaging in healthy lifestyle choices will really help in their recovery. But overall, we want to focus on performing occupations with the greatest independence and how we can incorporate that and help them achieve their goals and be able to go home or improve function and establish what things need to be done to help them get better and feel good. So that is all I have for today. Does anyone have any questions or would like me to elaborate further on any topics that I discussed? I'm gonna stop sharing the screen and I'm gonna see all your beautiful faces. There you go.
Mindy has something to say.
Yes.
Hi, sorry, my power went out, my internet went out, but I'm back on my phone thanks to Amy Germain's instruction.
That's all good.
I know. I mean, I just would say, oh my gosh, thank you so much.
You're
And
welcome.
your examples are fantastic. I really loved the example of how you integrated habits and routines into the hospital setting, right? Like
Mhm.
I think that we talk about that all the time, the importance of it, and you just gave such practical examples of that in a challenging setting. So that, oh my God, I
Yeah.
mean, you, I love all the things that your place is doing. Like, it seems like you're really cutting edge. You mentioned a few references I never even heard of, which is amazing. I did not know about the weight being 5 pounds, but it makes a lot of sense from a
Mhm.
proprioceptive receptor standpoint.
Yes.
And your self-care group. Oh my God,
Mhm.
your
Yeah.
6-step facial, like that is all of the things, all of the
Yeah.
things. And I was wondering if you happen to have like a written up protocol like that that you might want to
Mm.
share with somebody. Just saying. I'm not going to take up any more time. Other people might have more questions, but thank you. And when are you getting your doctorate and coming to Ithaca to work with us? That's all I have. Now I'm done with the talk.
I've thought about it. Any other questions? It could be simple. It could be if you want me to elaborate on anything. Any questions about school or field work?
I have a
I think
question,
Sophia.
Amanda.
Yeah.
So I work in outpatient peds,
Mhm.
but I do get, like TBI patients here and there. And my struggle is always like, I feel like I don't have the assessments that I need at evaluation. I'm like, oh, I wish I had like something else I could do. So I'm wondering like if there was like one thing that you're like, this is what I think would work in like an outpatient setting, like when you're thinking about your patients who might be going home and doing outpatient, like what assessments would you think of?
That's a good question. What like deficit are you thinking you would tackle? Like what, like something overall or a general one or?
I mean, honestly, like I'll tell you what I'm doing. Like a lot of my kids are like teens, and so I'm
Mhm.
doing like the real, which is like the role evaluation, because I'm like trying to see like ADL wise and IADL wise like where they're at. I almost wish I had like the COPA. Like I'm going back to school. I'm like I wish I could have them self
I
evaluate.
was just gonna say
Um,
that. Yeah. I
okay.
don't personally use the COPAM. And that's something that my colleagues and I, we want to kind of establish like specifically cognition, like a
Mm-hmm.
specific cognitive assessment to do because based on my facility is they go to the inpatient rehab, but then they come to us at the extended recovery unit. So like if they did it at that inpatient rehab setting, then I could do it again. So we're trying to establish the best cog measure for that.
Yeah.
I can't think of anything off the top of my head, Sophia, but I'll think about it and I'll let you know.
Okay. And two more things. One, totally stealing your self-care idea. I have a 17-year-old who I just started working with who like one of our goals is like painting her nails again. And I'm like, oh, we're
Mhm.
gonna have like a whole like self-care day. That's awesome.
Yes.
Um, and then the other thing is she was driving prior to her TBI. They live in Jersey and mom has had questions about like maybe doing some type of driver rehab. Do you have info on that you would not
Yeah.
mind sharing with me maybe?
Yeah, I can totally do that. Yes, for sure.
Thank you.
I think there's like a couple driving rehab programs in Jersey, but we are one of them. And they take them on the road or they do like a screening, of course, before they take them on
Hmm.
the road and do some evaluation measures. And then, teaching them adaptive tools like with the steering wheel and such. And then like taking them on the road with like it's similar to like how we go through driver school when we're getting our license. It's the same thing like on the passenger side there's the brake and things like that. But yeah, for sure I will send you over some info.
Okay. I have your number. I'm gonna send you my email.
Okay, cool.
Thank you. I appreciate
Yeah, no
it.
problem.
This
No
was
problem.
great. Oh, I had one more question. I'm sorry, I'm totally hogging. But so again, like I said, I don't get like a lot of brain injury, but I get some, and I'm like kind of looking into my continuing ed for the year. Like, do you
Uh-huh.
have a course that you think would be good for someone who's like, I'm not only working with brain injury, but like a weekend course or something that would like set me up to feel like a little bit more, I don't know, I guess, uh,
Yeah, like
prepared.
more
I guess
experience.
that's the
Yeah.
question. Yeah.
So TBI in general, like brain injury in general. I took an
Yeah.
awesome course with Shirley Ryan Ability Lab in Chicago. It was expensive, but it was like I believe it's like online and recorded, but it's I think I did it. When did I do it? Like 2022 I did it. And I did it from like February to May. It was like every Tuesday. You had to do some self-study stuff, but then there was lectures and it was awesome. It just gave you a good sense of like the basics and then it got
Hmm.
advanced as you went. Definitely look that up. I also did a vision course through them, which was awesome as well. Advanced vision for OT practice. That was pre-recorded. Yeah, look it up. It's Shirley Ryan Ability Lab. That's what you'll
Okay.
look up on the computer. Yeah.
Yeah,
But highly
I'll definitely
recommend
look
that
into it.
course. It's
Thank
it's
you.
lengthy, but it's worth it.
Didn't that used to be the Rehab Institute of Chicago?
I
Jenna?
don't know.
Oh,
Yes,
I just,
yeah, Shirley Ryan used to be RIC. It's just a different name, same center.
thank you.
Gotcha.
It's so funny, Amanda, because I did all my continuing ed in my first 5 or 6 years of life was at the Rehab Institute of Chicago. It's amazing. I know. Love it. Loved it. This.
Yeah, they have a great continuing ed program. Like it's very well established and it's really good. Any other questions? Jenna, I
Oh,
think I saw you had your hand
Oh
up.
yeah, Jenna, and then I'll go. Go.
Okay.
So I was just wondering if like because you talked a little bit about like TBIs and stuff like that. Oh, so sorry, I don't know what happened.
It's
Um,
okay.
but do you at all like work with like people and like do you have like a disorders of consciousness program or anything like that at JFK? And
Yeah.
like how do you, if you like work with that population, how do you kind of try and integrate like ADLs when appropriate kind of thing?
That is an awesome question. Okay, so JFK, my hospital, actually established the JFK coma recovery scale. And I don't know how old it is. It's pretty old, but it's old, yeah. Oh, thank you, Jenna. That's great. Um, so that coma recovery scale takes you through different protocols, and certain therapists have to be like specialized to perform it. I haven't had a coma, so disorders of conscious coma recovery scale kind of like goes hand in hand. I haven't had a patient of that in a while, but like you're gonna focus on vision or things like that, but it has different like subtypes. Like you could probably Google it a little bit just to get a sense of what that scale is and what areas you do focus. So like I have had the beauty of seeing someone emerge from that disorders of consciousness and then be able to perform an ADL. And the patient actually was at my inpatient rehab setting at the hospital, and then they came over to me at the extended recovery unit. She wasn't able to do anything. And then it's so to incorporate the ADL side of it, you got to just take it day by day and see how they're recovering naturally and with therapy, because it is a healing process, and it'll change day to day. And even the person that is performing that scale, they'll see improvement. You just do it like you would do like a 9-hole peg test or something. You do it maybe at eval and discharge. Like they'll do that coma recovery scale every Tuesday, say, and they'll see recovery in that way. Um, Something that I've done when they are in the coma recovery scale is providing still that neuroplasticity, like feedback and hand over hand, whether it's like a washcloth to their mouth or to their face to wash their face, like hand over hand, being able to wash their face, just to, talk them through it, providing the verbal cues, the visual cue, like here, this is the washcloth. It's a white washcloth. I'm going to put soap on it. Show them how you put soap on it. Rub it together, wash their face, things like that. So kind of still performing the ADL, but you won't do it as intensely, if that makes sense, or even using like a toothet. So something, if a patient's on a limited diet or they're not taking anything by mouth, they might have a feeding tube, is they'll use something called a toothet with like a solution. So it's like just kind of like a little swab, and it has like a little bit of kind of like a mouthwashy solution, and like kind of talking them through that, and like, providing that sensory input to their lips or their mouth, and, working on that. So basic grooming, and self-care with their hands and things like that would be how I would approach it.
Awesome, thank you.
You're welcome.
Amanda, I'm going to comment for a moment. I did joke with Mindy, like I didn't think I'd ever get a shout out in a neuro talk. So that's super exciting.
I
Thank you.
know, it's
Thank you for,
crazy.
like, helping me feel good for a moment. I do love like that transferability of content, really. It's we work across the lifespan.
Oh,
So I
yeah.
love how you note that proximal stability before distal mobility, and even with some of the questions that Sophia was asking. Are there other pieces that are like some of those transferable skills that you've noted, kind of like across the lifespan?
Something that I learned a little bit more by working at JFK was it's called like neurodevelopmental positions. And, a patient might be like a mod assist for a transfer, say you get them seated at a mat and you're going to get them on their hands and knees, and you're providing all of that stability and assistance. I provide through the upper extremity, the PT does lower, and we're at that trunk. So, working on like, well, of course we would go from like sitting to lying to prone to elbows, and then working our way up to quadruped, but like, it's such a similarity. You do that as a kid and you're learning that as a kid, but then you're also reteaching them, and you talk them through that, and you're providing all that input through their arm, and it's such great feedback to the brain, and to make those connections still. That's something that was really that I learned, and I use every day, or weekly, say. But that's something I would say off the top of my head. Yeah.
Yeah, very cool. Thinking of all those developmental movement patterns. Awesome.
Yeah. Or like I'll have the
Cool.
patient crawl. I'm like, all right, crawl. Like my one patient, she has difficulty standing, but she's able to pop up into quadruped. I'm like, all right, move forward, move back, like, like get a feel for it. So yeah.
Is there any more questions?
Sorry, I'm over time.
No, it's okay. Thank you so much for the presentation. It was really, really educational. I really enjoyed hearing it, and thank you so much for taking the time to give us the presentation. We really appreciate getting speaker series started once again. So I really appreciate you kickstarting that off for us.
You're welcome. Thank you for
yeah.
having me. Thanks to everyone for coming. I really appreciate it. And tell your fellow classmates if they have any other questions, or if you're going through any, stroke-based courses. I don't know if Shannon still teaches the adult blocks and all that jazz. I was hoping she was on tonight, but hopefully she can view it. Yeah, no power. But yeah, tell her to reach out to me, or I'm more than willing to do a little talk during her class too, if that's helpful. But yeah, thanks so much, guys.
Thank you so much. Just a reminder to everyone that the video and the transcript will be provided on YouTube, and just as like a promotional for the next one, the next one will be Erin Looney and Mackenzie Perkins on March 27th at 8 p.m. instead of 7, and it's going to be on Travel OT.
Cool. All right.
So thank you for coming, everyone.
Thank you.
Thanks, Amanda. Great to see you.
Great to see you guys too.
Yeah, so fun.